Hello, Insta family. How are you all doing on this wonderful Wednesday, hump day? We're on the downhill run to the end of the week, and I am on the downhill run to the end of my radiation therapy, which finishes on Friday. So super duper excited for the end of that. I have a couple of questions already sent through on DM for me to answer. So while I'm doing that, you can drop any questions you like into the comment section, chat box. So remembering, of course, let's keep the stories nice and straightforward and simple. I'll be giving you straightforward answers. Don't need to share your life story, but any question is a valuable one because I can promise you that there is somebody else out there who is wanting to ask the same question. Yes, I have dyed my hair. My daughter called me the silver fox the other day, so the greys have gone. But I do recognise I probably need to go to a proper hairdresser and get a really good job done. But while it was this short, I thought I could get away with a box job. Anyway, right, so a couple of questions already before anyone drops something into the comments. Somebody has asked me about lean PCOS, and they've characterized themselves as lean PCOS with low testosterone. So I don't know the rest of the clinical scenario, but there's two aspects of this that I want to talk about. The first thing I want to talk about is that you've got to make sure you've got the diagnosis correct. So lean women may also have something called hypothalamic hypogonadism. So it's as a result of the hypothalamus not talking to the pituitary gland, and therefore the pituitary gland not talking to the ovaries. And some people confuse this as PCOS because the outcome is very similar, no or very few periods. So you've got to make 100% sure that you've got the diagnosis. And often in lean PCOS, it is very difficult to make the diagnosis. But one thing I find that's really discriminating is the size of the ovaries. So the ovaries are still really bulky. With hypothalamic hypogonadism, there is still often many follicles, but they're much smaller than in true polycystic ovarian morphology. You also find with hypothalamic hypogonadism is that the androgens are very low, the prolactin's very low, the thyroid function's very low, everything is very quiet. Whereas in true PCOS, you will have a hyperandrogenism often. So I think it's really important, as I said, to get the diagnosis correct. If this is true lean PCOS, then you'll often have the no periods thing, you'll often have a low body weight. You won't often have the metabolic features, so you might not have the high levels of insulin, you might not have the high cholesterol, abnormal cholesterol, you might not have the weight issues, and hence why you're called lean PCOS. There is still a role of metformin. We know metformin is important for two reasons in IVF. Firstly, to reduce the chances of ovarian hyperstimulation because the egg count is often really high, and IVF, there is always that risk. But metformin actually might help with inducing ovulation itself. So we still use metformin, even though there's not that insulin resistance, we still often use metformin in that case. So really good question, but I think food for thought, make sure that the diagnosis, excuse me, got a frog in my throat, make sure the diagnosis is correct, and then think about the role of metformin and the role of IVF. So somebody else has asked me about growth hormone. Is there anyone else that is posting any questions, or are you just all on a knife's edge to hear my answer? No more questions there. So what is the role of growth hormone? So there was a theory and biological plausibility that we know that human growth hormone is quite important for follicular development. We know that that is one of the important hormones that helps to improve quality of eggs. So for many years, retrospective, so looking back at data from clinics, has suggested that the introduction of synthetic human growth hormone may help improve egg quality and therefore increase the chances of pregnancy. However, a large multi-centre randomised controlled trial was done in Australia and New Zealand a few years ago, and the study was unable to show an improvement in pregnancy rates by introducing growth hormone. And that's considered level 1 evidence. And this study was done in a population of poor responding, so largely older women who are expected to have poorer quality eggs. So when you've got level 1 evidence, it kind of trumps data collected from clinics retrospectively. And so my thinking about growth hormone is that it probably does not have a role. Until there is some really good quality evidence, it probably does not have a role in significantly increasing the embryo quality and therefore the pregnancy rates, which is actually what you guys are most interested in. Not only that, but growth hormone is ridiculously expensive. Like per injection, it's a very expensive drug. And often women will have to take it for a long period of time. So it just adds treatment burden and doesn't necessarily increase your pregnancy outcomes with any greater significance. So it is not a drug that I work with, nor is it a test that I routinely perform on women. All right, Emma Green 86, silent endo, are there any subtle signs? Well, I suppose, Emma, that is probably why it's termed silent endo, because there are no symptoms that are experienced aside from perhaps presenting with infertility. So it is fairly well understood that up to 40%, so 4 out of 10 women who present with just "we can't conceive with my partner" will actually have endometriosis present, and therefore it may be implicated in their diagnosis. So they don't have painful periods, they don't have painful sexual intercourse, they don't have any signs on an ultrasound, they simply present as being unable to conceive. And so that's one of the great difficulties that we have as clinicians is, do we go ahead and do a laparoscopy as part of our basic management? Well, certainly with minimal to mild endometriosis, resection of that endo could increase spontaneous pregnancy rates. But we also know that IVF will overcome the impact of that stage of endometriosis. So simply moving someone onto IVF may be a quicker and easier way to deal with it. As far as stage 4 and 5 disease, it's 3, 4 and 5 disease, severe endometriosis, often surgical resection is not helpful either, and we often need medical management and suppression of endometriosis in combination with IVF. So, sometimes we might not suggest going to a laparoscopy simply to diagnose it, because it might take us off track with what we really need to be doing, and that's moving ahead with fertility treatment. So hopefully that has been a good answer. Rach Perry Pilates, good to hear from you. Frozen versus fresh sperm for ICSI. Will freezing sperm affect the quality? It's probably not going to affect the quality. We always say fresh is best because we have nice motile sperm at that time, and motility is one of the things that helps us choose a sperm. And so frozen sperm aren't often as motile, so there's probably less to choose from. But I don't believe that it affects the quality itself, and certainly doesn't necessarily decrease fertilization rates or embryo development rates. So good question though, really like that one. Sashwa, good to see you on here too. Dr. T, do Overdrill clicks as luteal support need to be given at a specific time? My days have changed cycle to cycle and looks like it's not uniform from Google research. Very, very astute of you. So Overdrill is HCG. It has quite a long half-life. And so you're absolutely right. It is given in lots and lots of different ways. Some people give it every 2 to 3 days. Some people give a lower dose every day. There is no one hard or fast protocol for use. What I can tell you though is the research generally indicates to us that giving progesterone in luteal phase support is more associated with higher pregnancy rates than actually giving Ovidrel to support the corpus luteum. So additional Ovidrel is not thought to be helpful in addition to the progesterone and it's avoiding another injection. So I think my thinking on this is preferentially giving you progesterone for luteal phase support over HCG, and I don't need to add it in either. Rach Goodsell, hi Tamara, there are questions in the question box. More questions? Or you mean the inbox? Or maybe you're just reminding me that I've found them. I've found the questions in the question box. Because I did get a couple of DMs earlier and I did respond with the answers to those questions. I'm sorry if I have missed your question in my DM. Oh, here we go. What would you say to a healthy 30-year-old with an AMH of 0.5 and 3 antral follicles in total? Well, my first thing would be we need to help you get pregnant. If you are having difficulty, actually, let me backtrack on that. If you're a healthy 30-year-old and you are not yet trying to conceive, but you have a partner or you're open to donor insemination, I would be encouraging you to get pregnant sooner rather than later, because those two things don't actually tell us how fertile you are. Your fertility is most associated with your youth, and at 30 you're really young. What an AMH of 0.5 and 3 antral follicles does suggest to us that your ovarian reserve is low, and it is quite possible that you'll go through menopause before the age of 40. You could consider egg freezing if you're not in a position to move forward with having a baby now, but we know that it will take you several cycles to store enough eggs to give you any guarantee or any high probability of a live birth in the future. So yes, IVF and IUI are absolutely possible. You will not respond prolifically, but what you do produce will be of good quality because you are young. So let's hurry up and get pregnant is my first thing that I would say to you. Christy Annette, is there such thing as too many egg collections? Does it have a negative effect on your body? Great question, Christy. There have been studies done looking at the number of IVF cycles that women have and risks such as estrogen receptive cancers like breast cancer or endometrial cancer, and there doesn't appear to be any increased risk except in one population, and that is women under the age of 28. So there seems to be a slightly increased incidence of breast cancer in that population. This is all association-based research, so it's not causative. There may be other confounding factors associated with that. But I also know that just, doing cycle after cycle, anyone on here who's done several cycles will be able to tell you that the process is quite burdensome, it's quite tiring, it's quite challenging to your mental health as well. But as far as big data suggesting to us any associations with cancers, very, very minimal. Okay. Does that not class as infertile? Having a low AMH and having a low antral follicle count does not classify you as infertile unless you've tried. The definition of infertility is where you and a partner have tried for, at your age, at least 12 months, but you might have not 12 months. So what we are talking, therefore, about is considering fertility preservation. But it's certainly worth a discussion with a fertility specialist who will talk to you about those things. Well, guys, I've got to wrap it up because I've got to go and pick up my daughter from swimming. Thank you so much for all of those questions. They were fabulous. Hopefully they will be of value to others as well. So thank you for asking them. Thank you, everyone, for all of your support in my treatment. It is nearly over. 2 more sessions of radiation, and I will be able to celebrate. Jacqueline Harris, beautiful answer, Dr. T. I love your holistic perspective on that question, re multiple stim cycles. Thank you, Jacqueline. Thank you. Ladies, gents, if you're on, have a beautiful rest of your week. Make sure you share all this material with people. We want to make sure they're all getting the right information out there. Have a great week. I'll let you know how I go after I've finished all my radiation. See you soon.